welcome to all of our attendees. I'm going to introduce our speaker in just a minute, but I'd like to add a few additional housekeeping items. The slides are available for download now. Within 2 weeks, you'll also be able to view the webinar and download slides at LifeScanDiabetesInstitute.com. There's no charge for LifeScanDiabetesInstitute.com membership, but if you've forgotten your password, there is a self-service password reset available. Please feel free to submit questions during the presentation. We'll get to as many of them as possible at the end, and all unanswered questions will be addressed in a post-webinar blog. Now it's my pleasure to introduce our speaker, Dr. Juan Frías, who is President and CEO of National Research Institute in Los Angeles, California, and is on the clinical faculty of the Department of Endocrinology and Metabolism at the University of California, San Diego. He's held numerous leadership positions within major pharmaceutical companies, medical device companies, and academic institutions. Dr. Frías has been involved in diabetes and metabolism-related research for over 20 years and has authored numerous publications in the field. He's spoken for us many times, and it's my pleasure to introduce him and work with him once again. Dr. Frías, the floor is yours.
Okay, well, thank you very much, Mary, and welcome everyone. And I'd like to thank the LifeScan Diabetes Institute for this opportunity. So we'll be talking over the next 40 minutes or so about some of the standards and guidelines. As you well know, as healthcare practitioners in the field of diabetes, many of you, this is just an ever-changing field. You know, over the past several years, there's so many new medications, diabetes-related devices, and importantly, new evidence that we need to sort of keep track of and continually be changing our practice patterns in order to serve our patients as well as possible. And we clearly can't cover everything, so I'm going to highlight some of what I think are some of the key sort of new either treatment guidelines or with respect to glucose control or also cardiovascular risk, and also with monitoring as well. And as we know, and these are actually quotes that come from the latest ADA diabetes standards of care, that diabetes is a chronic disease, and it really is a multifactorial disease. So although glucose and high glucose defines the disorder, our patients, particularly our patients with type 2 diabetes, have many comorbid conditions, and these need to be assessed and treated as well, particularly cardiovascular risk. And we're seeing more and more also fatty liver disease, which is very important, but other risks as well that we'll be touching on. And clearly there's very strong evidence, and we're continuing to get more evidence, it seems like almost daily, about the range of interventions and the types of interventions that can ultimately help our patients achieve better outcomes. So if we look specifically at glycemic control, and this is not just the ADA guidelines, but AACE, IDF, and a number of other guidelines, and I've just got a few of them there pictured on the right, but clearly lifestyle management is critical. So good diet, physical activity. I would add to this list, education is absolutely critical to our patients with any chronic disease, but I think particularly diabetes. Individualization of not only of treatment goals, but also of therapies for patients, extremely important. Metformin and diagnosis, and we'll talk a little bit more about that, but unless there are contraindications, every patient should be placed on metformin at the time of diagnosis, and I'm speaking of type 2 diabetes here. And if we look at recent guidelines and recent recommendations, clearly accelerating therapy, so even considering combination therapy at the get-go, at diagnosis, but certainly combining agents and doing so more quickly to avoid therapeutic inertia and long periods of hyperglycemia. So we should intensify therapy in a timely fashion. We have a number of classes of agents today which address the many pathophysiologic defects in type 2 diabetes that contribute to hyperglycemia, and we should be combining these sort of in a rational manner that takes into consideration their complementary mechanisms of action. And now that we have agents with proven cardiovascular benefit and benefits with respect to CKD or chronic kidney disease, we should be considering these aspects as well in deciding which agents to use. And as always, we need to consider not only drug-specific, but patient-specific factors. and including the cost of the medications, and then whether patients, might have injection phobias, might have different conditions which would not allow them to use certain agents, and also just how complex a regimen is, because we clearly want to make sure that patients are actually being adherent and persistent with their therapy. So here I just wanted to show a screenshot of the guidelines. So if you don't know, and I think many of you probably do, the American Diabetes Association puts out standards of care once yearly, and it comes out in January in the first supplement of the journal Diabetes Care. And over the past 2 years, they've had sort of the full version, which is hundreds of pages, and then also an abridged version, which I think is very nice, which summarizes the key recommendations. And I think I have the website towards the end of the presentation, but you could just Google Standards of Care, American Diabetes Association, and this is downloadable and it's free. And I would definitely recommend that you take a look at these. I think it's very important. And as part of this, and this is in the glycemic management of type 2 diabetes, I think this is something definitely worth taking a look at in the Standards of Care document, and its so-called decision cycle. And not to go through this in any great detail, but it talks about the importance of starting on the left upper corner of reviewing and agreeing on a management plan with the patient. So ensuring that modification of therapy is implemented in a timely fashion and avoiding clinical or therapeutic inertia. Just kind of moving around the right, they're assessing key patient characteristics, so the patient's comorbidities, as I mentioned, whether they have atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease, what is their age, their baseline A1C, their body weight, because this can influence which types of agents we use in patients. Moving down, considering specific factors that impact the choice of treatment. Again, one of the bullets here speaks to choosing a regimen that will optimize adherence and persistence. I think this is oftentimes the issue. I mean, obviously we can have a lot of different classes of medications and a lot of different medications, but if patients don't take them, it's not going to do us a whole lot of good, or them a whole lot of good, I should say. So adherence and persistence is very key. Shared decision-making is critical, and I think, with the first bullet there, I think is absolutely critical to make sure the patient is educated and is informed, and that's where the diabetes education is critical. And I think this is not only important to the patient, but also the patient's persistence with their therapy, that they understand what the therapy is doing and what their targets are and what their goals are, and understand some of these labs. Having smart goals, so specific goals, and I think realistic goals for the patients as well. I mean, I think all of you, have different ways of doing this, but certainly when I get a patient that comes into the clinic and their A1C is over 14, my goal is not to get them to less than 6.5 in 3 months, or even communicate that, because I think that sets them up for failure, but to slowly get them to good glycemic control and have very realistic sort of intermediate goals as we get to the ultimate goal, which may be less than 7.5, 6.5, again, individualized to the patient. Moving around, implementing a management plan, and the key here is making sure the patients get appropriate follow-up, that we're following the A1C, again, with respect to glycemic control. And if the patient is not achieving their targets, making sure that they are being adherent with their medication. And if they are, then advancing therapy. As you well know, most patients will require more than one agent to achieve their glycemic goal. I think the last one here is very important, an ongoing monitoring and support, which includes biofeedback, such as, and we'll be talking more about self-monitored blood glucose, very important not only for patients on insulin therapy who make, oftentimes, day by day or within a day therapeutic decisions based on SMBG, but also monitoring in patients who are on oral agents, who can learn a lot about their glucose control, their diet, their medications based on this type of monitoring. So I would encourage you to look at this in more detail in a very nice section in the guidelines. Now, if we look at type 2 diabetes, obviously a very complex disease, and this looks at 8 of the key organs or tissues that are implicated in hyperglycemia, so where there are defects, if you will, that contribute to hyperglycemia. And I think we're very fortunate today to have a number of different classes of agents which address many of these defects, to improve glycemic control. And if we look at the sort of the optimal management of dysglycemia or hyperglycemia, oftentimes does require using multiple agents with complementary mechanisms of action to reduce glucose. And our goal really is to reduce the glucose in a way that's as safe as possible. So really avoiding hypoglycemia and avoiding unnecessary weight gain in patients with type 2 diabetes. So let's talk a little bit about screening and diagnosis. So here I'm going to turn it over to Mary for our first polling question.
Great. So our question asks, in the U.S., approximately what percentage of patients with diabetes are undiagnosed according to the CDC? A, 25%, B, 5%, C, 10%, or D, 55%. And we'll give the attendees a moment to answer the question. And while we do, one of our questions that has come up asks, since diet is so important in diabetes management, what are your thoughts about time-restricted eating or fasting?
Yeah, that's a good question. And I think, in general, the general thinking would be that really it just, I think the best diet is one where it's just sort of restriction kind of across the board of caloric intake. So not necessarily any fad diet or any, ketogenic diet or any diet that's, low in any one particular macronutrient. So I think it could be helpful to some patients. Clearly, I think we need to be very cognizant of the fact that if patients are on insulin or on insulin secretagogues, that it could increase the risk of hypoglycemia. So, not the greatest answer here, but I think it needs to be individualized. But in general, I would say that just good portion control, reduction of overall calories, and a nice balanced diet is probably the most realistic, the one the patients can stick to, and should afford the patient, if there is at least 500 calorie sort of deficit daily, should cause them to have reasonable weight loss over a reasonable period of time.
Great. Would you like to address the answers, please?
Yeah, so the correct answer here is 25%. It's actually a little less than a quarter of the patients. So the vast majority of you got that correct. So there are approximately 30 million people in the U.S. that have diabetes. As you know, about 90 to 95% of that is type 2 diabetes. And unfortunately, about a quarter of those patients are undiagnosed. And those are clearly patients that are very high risk of complications because they're not being treated. And I think, we do at our center, we have a very large type 2 diabetes clinic, and we run a lot of clinical research and have been doing so for about 30 years. And we do a lot of community outreach and screening at health fairs. And it's not unusual where I could go out in Los Angeles and in one weekend, find 10 patients that end up having A1Cs over 14% and are completely asymptomatic. It's such an insidious disease and so slow in its onset. So we need to be doing a better job, I think, in screening patients as well. So if we move forward here, this goes over, and this again is from the ADA guidelines, and talks about screening for asymptomatic adults for prediabetes and type 2 diabetes. So if a patient has typical symptoms of type 2 diabetes, so polyuria, polydipsia, weight loss, those patients need to have an A1C or a fasting glucose checked immediately. But as far as asymptomatic patients, a recommendation for adults is anyone with a BMI of over 25. So if a patient is overweight and of Asian, over 23 kilograms per meter squared, who has at least one other risk factor for diabetes, and they're all listed there. And this, quite frankly, is going to end up being almost everybody, because these other risk factors include physical inactivity, first-degree relative with diabetes, being from a high-risk ethnic group. So it's almost anyone. But if they don't meet those criteria, screening should occur at least at age 45. It should also occur in patients with prediabetes, so who already have been determined to have prediabetes. They should be tested yearly. In women with a diagnosis of gestational diabetes, these patients are at very high risk of developing type 2 diabetes. They should be tested at least every 3 years. And then in these patients, if they're screened and they have basically a normal test, they should be tested at a minimum of every 3 years. And this could be with either a fasting glucose, a hemoglobin A1C, or a 2-hour oral glucose tolerance test. So this would be 75 grams of glucose. And obviously the easiest ways to test are with a fasting glucose or an A1C, quite frankly, because that, although it's more expensive, does not need to be done in the fasting state. So here you see the criteria for diagnosis. So over 126 fasting glucose, a 2-hour postprandial glucose or post-challenge glucose during an oral glucose tolerance test of over 200, an A1C of 6.5 or greater, or in patients with just a random glucose of over 200 anytime during the day with symptoms. And that defines diabetes. So we'll go to the second polling question here.
Okay, great. So our next question asks, true or false? Unless there's a clear clinical diagnosis, the diagnosis of diabetes requires 2 abnormal test results from the same sample or in 2 separate test samples. True or false? So we'll let our attendees answer that. And while they do, we have another question that asks you, is that supposed to be HDL less than 35, not more than 35?
I don't know where, I don't think I've spoken about HDL at this point, but, you know, you want to see HDL, you want the higher the HDL, the better. Let me see if it's in here. Oh, in the risks. Yes, it should be less than. I'm not sure if it was, you're absolutely right. HDL cholesterol less than 35. So that's a typo there. Very good question. For clarification.
Well, it looks like most of our attendees have answered, so would you like to go ahead and address the results?
Yeah, very kind of split results here, but 57 or 58% got the correct answer, which is true that it should be 2 abnormal tests. And the change this year is that it can be from the same sample. So previously, it would be 2 separate samples, perhaps generally on 2 separate days. But it can be, for example, if you drew blood and sent an A1C and also had a fasting glucose and they were both above the threshold, that patient, per the guidelines, would be diagnosed with type 2 diabetes. For example, the fasting glucose was 130 milligrams per deciliter and the A1C was 6.7%. So, or it could be done separately, and we'll go through that in the next slide with respect to the diagnosis. So with respect to confirming the diagnosis, so if there is just a clear clinical diagnosis, again, with all of the symptoms, it should require 2 abnormal tests. And these tests can be done from the same sample, as I just explained, or on 2 separate samples. If one test is abnormal, the second test should be performed without delay. So if you just got a fasting glucose and it was 140, as soon as possible, you could either get another fasting glucose or do another test. And generally, the easiest one would be an A1C or vice versa. But this could be 2 A1Cs, 2 fasting glucoses, any combination of these. If 2 tests are done on 1 sample, and one test is diagnostic and the other is not, and I've given an example here, an A1C of 6.6 and a fasting glucose of 120. So this shows a fasting glucose in the prediabetes range, which is 100 to 125. Then the abnormal test should be repeated. So here you would repeat a hemoglobin A1C, and this should be done, as soon as possible. And if the test results are near the margins of the diagnostic threshold, so not quite meeting the diagnosis, but very high in the prediabetes range, then there should be very close follow-up. And the recommendation is to recheck one of the tests or both of the tests in 3 to 6 months. So I think the bottom line is, unless there are unequivocal clinical signs and symptoms of diabetes, that we should rely on 2 tests, and those tests can be either the same test, fasting glucose A1C or oral glucose tolerance test, or some combination of the 2, but they can be done on the same day with the same sample to make the diagnosis. So now I'd like to just briefly talk, about other tests and other assessments that should be done for comorbidities, and the need to be followed here as well in patients with type 2 diabetes and diabetes in general, I should say. So the approach is not just, again, about glycemic control clearly, but many other comorbidities that could exist along with the diabetes. I'm certainly not going to go over all of these, but I would say, the guidelines go over this, I think, very nicely, but immunizations are key, particularly flu shots and pneumococcal vaccines. In patients particularly with type 1 diabetes, as you know, oftentimes they can have autoimmune thyroid disease or celiac disease. I think this would be important in many patients to check for that. One that's important, particularly for men, and this came out in the guidelines last year, certainly if they have any symptoms of hypogonadism or decreased libido, not just to blame this on the diabetes per se, but to check a fasting testosterone level. Fatty liver disease is becoming more and more common, and now with the cure of hepatitis C, fatty liver disease, it's estimated, will soon be the number one cause of liver transplantation in developed countries. So patients with type 2 diabetes that are at a much higher risk of having fatty liver disease, both simple steatosis, so NAFL, as well as NASH, or non-alcoholic steatohepatitis, which ultimately can lead to increased fibrosis, cirrhosis, and potentially liver failure. So this is something that, although there are no medications approved specifically for NASH today, there are many, many medications in development, and it's becoming a field. We're doing a number of studies in this in our patients with diabetes, and I think we'll be hearing much more about this in the short term now. And obviously psychological disorders, depression is more common in patients with diabetes. Oral hygiene and oral health, very important as well. So with respect to diabetes prevention, just to touch on this, the recommendation, and this has been a long-standing recommendation by the ADA and other societies, is although it's not FDA approved and it is off-label for metformin, metformin, as you know, was studied in the diabetes prevention program and did significantly improve the progression from prediabetes to type 2 diabetes, particularly in the subset of patients who were obese, who had a BMI of over 35, and who were under 60 years of age. So the recommendation by the ADA is at least to consider metformin therapy in that patient population, and also women with previous gestational diabetes. I would also say that in patients who have an A1C of over 6%, so prediabetes is 5.7 to 6.4, or whose A1C has been rising over time, if you've been following it, and is sort of moving into just very close to the 6.5, the diagnosis. Oftentimes those are patients, certainly in my experience, that I will initiate on metformin as long as there are no contraindications. So those patients with prediabetes who are at higher risk of developing type 2 diabetes. And then one other, this has been known for some time, the chronic metformin therapy may lead to B12 deficiency, but there has been some recent data from the diabetes prevention program sort of confirming this. So the recommendation is, particularly in patients who have anemia or who have neuropathy, to check a B12 level. There definitely is an association between chronic metformin use and B12 deficiency. It's something that's very easy to treat. So many folks are recommending checking B12 levels in patients on metformin therapy. Annually, I think would be very reasonable, and particularly those patients with anemia and peripheral neuropathy, and it could also cause cognitive impairment. So very important to check that. So let's move on now to pharmacological approaches, so medication treatments. And we have another polling question here. Let's go.
Number 3, true or false, GLP-1 receptor agonists should generally be the first injectable class of agents in the treatment of type 2 diabetes. True or false? And while our attendees answer that, an interesting question came up. And it asks, is diabetes hereditary, or is the poor lifestyle the hereditary factor?
Oh, that's a great question. And, it's actually both. But type 2 diabetes is very hereditary, certainly much more than type 1 diabetes. So family history of type 2 diabetes is one of the biggest risk factors for development of type 2 diabetes. But, there are many patients, who have very high risks or genetic risk, but, stay thin, stay very active, and then the diabetes may not come out. But certainly if they start increasing weight and there are sort of those issues with lifestyle, then they have an increased risk. And in a sense, that's sort of what happens with gestational diabetes. These are women who usually have a family history. They get pregnant, which causes significant insulin resistance. They have diabetes during the pregnancy. Once they deliver the baby in the placenta, the insulin resistance goes down, sort of the hormonal milieu changes, and the diabetes goes away, but they remain at very high risk of diabetes. So very strong genetic component in association with lifestyle. So both are correct.
All right.
Okay,
so
let's go to the question. Yeah. So the answer here is true as far as the guidelines go. So I can tell from this answer that most of you are very well educated about diabetes, because these are sort of the latest guidelines from the ADA. Where the first injectable, now again, unless there are contraindications to the use of a GLP-1 receptor agonist, of course, should generally, and I say generally because there are obviously exceptions, be a GLP-1 receptor agonist. So you have patients on oral agents, you need to intensify the patient, and it's time for an injectable therapy. Generally the GLP-1 receptor agonist, because of the low risk of hypoglycemia, the positive weight effects, the potential positive cardiovascular effects, and it can be given once weekly oftentimes with some of the formulations, so it's relatively easy as well. But there are situations where insulin, particularly in patients who are catabolic, who are extremely hyperglycemic, where insulin is important. And generally, at the end of the day, you probably will need both injectable agents. So if we look at the recommendations, we already talked about this. Metformin is a preferred initial agent. Other agents, if needed, should be added to metformin. So if you have a patient on metformin not achieving goals at 3 to 6 months, you don't stop the metformin. You add agents to the metformin. And we should consider early insulin if, this is what I was mentioning, there are symptoms of catabolism, so patients are losing weight, or symptoms of extreme hyperglycemia, or the A1C is over 10 and the blood glucose is over 300. I mean, insulin really has unlimited glucose lowering effect, limited, I should say, only by the risk of hypoglycemia. The guidelines do recommend initiation of dual therapy in patients who are newly diagnosed with an A1C 1.5 points or percent over their target. So if I have someone and I determine, hey, their target at the end of the day needs to be less than 7%, and they're 8.5, 9, maybe 10, this is where I might consider initiating therapy with 2 oral agents. And this could be metformin with an SGLT2 inhibitor or a DPP4 inhibitor. Depending on insurance coverage, it may have to be a sulfonylurea, but certainly consideration for dual therapy, because when the A1C is that high, it's oftentimes difficult to get patients under control with one agent. And it definitely needs to be a patient-centered approach with a lot of different considerations in deciding what therapy to use. In patients with established atherosclerotic cardiovascular disease, there are SGLT2 inhibitors and GLP-1 receptor agonists that have shown cardiovascular benefits, and these agents should be used after metformin or initially in combination with metformin in that patient population. And certainly if a patient has, I should say, heart failure, not heart failure, the SGLT2 inhibitors are very important. In patients with chronic kidney disease also, there are SGLT2 inhibitors and GLP-1 receptor agonists that have had benefits. So again, these are 2 key considerations that in the guidelines are discussed quite extensively. The atherosclerotic risk, those patients who already have heart disease or stroke or peripheral vascular disease, in patients with chronic kidney disease. And in most patients who need injectable medication, and this is the answer to the question, the GLP-1 receptor agonist should be preferred to insulin, and intensification should not be delayed. So we should always be avoiding therapeutic inertia. And there have been a number of studies, and these are retrospective studies, countless studies that have looked at databases and looked at how long it takes to progress therapy, and this is just one of many, and you can see going all the way on the left there, from one oral agent, this is in the UK, in several thousand patients, adding the second oral agent took an average of 3 years, and this were 1.6 to 3 years, and this is in patients who were poorly controlled. Going to the third oral agent as much as 7 years, and then adding insulin another 7 years, and then intensifying the insulin with either a GLP-1 receptor agonist or basal bolus insulin or going to premix another 3 years. So a lot of time here spent in hyperglycemia with significant glycemic burden, if you will, and increased cardiovascular risk. And this really is what we're trying to avoid by intensifying early and really be a more proactive and more of a, I would call it, a simultaneous or combined approach rather than a sequential approach, which can often take a lot of time. Just very briefly, this is the American Association of Clinical Endocrinologists guidelines for initial therapy, and it's based on the A1C. So if you look all the way on the left at the entry A1C, so a diagnosis is less than 7.5, they recommend metformin as sort of the lead medication, you can see there. But if the entry A1C, they say, is over 7.5, this is when we should be considering dual therapy. This is even more aggressive than the American Diabetes Association. And if the entry A1C, so the A1C is greater than 9%, they even recommend, dual therapy or even potentially triple therapy. Now, you have to say I've not generally done triple therapy. I think that may be overkill, but it at least is a consideration. And certainly if the patients are having symptoms, just like the ADA, to consider insulin therapy. And very importantly, the importance of following the patient, and if control is not gained within 3 months, and we've confirmed that the patient is adherent with medication, to then move forward with another agent and intensify. So there's no real right or wrong, but it just needs to be done relatively quickly and safely, obviously. One important combination, though, is the combination of basal insulin and a GLP-1 receptor agonist. So oftentimes, I think many of us have patients that are sort of maxed out on their oral agents. So they may be on metformin, an SGLT2 inhibitor, or DPP4 inhibitor, not getting to control. And then we start them on an injectable agent. And as we just heard, and I saw that most of you put that in your answer as well, it may be a GLP-1 receptor agonist first. But many of those patients then don't achieve their glycemic target and then need basal insulin added, so basically 2 injectables. And I think that these really do have complementary mechanisms of action. If you look at what I showed before, the so-called ominous octet, or the 8 key defects, between basal insulin and a GLP-1 receptor agonist, 7 of those 8 defects are addressed or covered. The only one that's not covered is the increased reabsorption of glucose at the level of the kidney, which is covered by the SGLT2 inhibitor. So this is a very nice combination, whether it's done sequentially, starting with the basal insulin and then if needed adding the GLP-1 receptor agonist, or vice versa. And also, as you know, we do have the fixed ratio combinations now. So Iglar-Lixi, which is insulin glargine with lixizanitide, and Ideglira, which is insulin degludec with liraglutide. So both of these medications in one daily injection, which adds convenience, and I think is very appropriate for, the selected patient. And this is a slide that I got from my good friend Steve Edelman, which makes the point that, over 45 type 2 diabetes treatment options, not many of these are fixed dose combinations of medications or medications, multiple medications in similar classes, but it's even more now since this slide was made. And despite that, sort of in general, the A1C in the U.S. has not changed a whole lot. So we've had a lot of advances, particularly in pharmacotherapy, which speaks, I think, to the importance of education, of being more proactive and avoiding therapeutic inertia, and then also of making sure that we have regimens for our patients that they actually can afford and that they can follow. So cardiovascular disease, critically important. So this is the number one cause of death in patients with type 2 diabetes. So, glycemic control, critical, obviously, but along with that goes the importance of reducing cardiovascular risk and treating modifiable cardiovascular risk factors. This is not only true of type 2 diabetes, but also of patients with prediabetes and also of patients with fatty liver disease, which, up to 70% of our patients with type 2 diabetes have. So critically important. And I'm going to focus on hypertension just because there were several changes this year with respect to hypertension. And we'll talk a little bit about lipids as well and aspirin therapy. But blood pressure should be measured at every routine clinic visit. The recommendation is for all hypertensive patients to monitor their blood pressure at home. So they should have an automated cuff at home. We will generally prescribe one. It's generally covered. If not, they're not that expensive. And we generally will have the patient bring that to the office so we can just make sure it's sort of calibrated or working against our monitors. Targets should be individualized. And as you'll see, I think in probably Bill's here. Yeah, so for patients who are very high cardiovascular risk, the target should be less than 130 over 80 millimeters of mercury, as long as that could be achieved safely. And these are generally patients, if you do a 10-year risk calculation, what's in the guidelines is if it's over 15% risk over 10 years, that this should be the target. And then for lower cardiovascular risk patients, less than 140 over 90 is okay. But, without a doubt, we should try to get our patients less than 140 over 90. And this, as with glycemic control, oftentimes, or more often than not, means combination therapy with antihypertensives. And I don't know how well this shows up, but this is, I think, a very nice sort of algorithm, if you will. And again, it's a treatment recommendation that's based on the initial blood pressure measurement. I'm basically saying that if the initial blood pressure is less than 160 over 100 millimeters of mercury, to start with a single agent. And then which agent will depend on whether the patient has albuminuria or not. So a spot urine should be done in these patients anyway as part of renal monitoring. But if they have microalbuminuria or frank proteinuria, they should definitely be started on an ACE inhibitor or an angiotensin receptor blocker, so an ARB. Otherwise, they can be started on a calcium channel blocker or a thiazide-type diuretic. So you do want to use agents, so ACE inhibitor, ARB, dihydropyramide, calcium channel blockers such as amlodipine or nifedipine, or a thiazide-type diuretic, because those have been shown to improve cardiovascular events and cardiovascular risk in patients with diabetes. They should all be managed with lifestyle management, certainly weight control, so the DASH style diet, moderate or no alcohol use as well, which can increase blood pressure. And then starting with those agents and then monitoring, and if patients are not achieving their targets, combining therapies. But the other recommendation on the right there is for patients who initially are very hypertensive, so over 160, over 100, and the recommendation would be to start two agents, so combine two agents initially. So this could be a calcium channel blocker with an ACE inhibitor or an ARB. So any combination. The one combination that's not recommended, though, is combining an ACE inhibitor with an ARB. So there generally is not much improvement in blood pressure, and there definitely is an increased risk of side effects, particularly decrease in eGFR, so reduction in renal function, and increases in potassium. So I think as we treat the glucose, we need to be watching the blood pressure very carefully, because improvement in blood pressure not only improves cardiovascular risk, but also microvascular risk, retinopathy and nephropathy as well. So a critical part of the management of a patient with type 1 or type 2 diabetes. Dyslipidemia, obviously very important. And for the most part, particularly patients over 40 years old with type 2 diabetes, almost all of them, unless there's a contraindication, should be on a statin. It just depends whether they're going to be on a high-dose statin, atorvastatin 40 to 80 milligrams, or rosuvastatin 20 to 40, or moderate dose statin. And then if they're less than 40 years old and high risk, they should be on a statin. If they're lower risk, I think then we just need to individualize, and some may not. The vast majority of my patients with type 2 diabetes are on statin therapy, irrespective of their LDL cholesterol. So there's some very good recommendations and tables in the standards of care that I would recommend you look at. Smoking, obviously, very difficult to stop smoking. I think, these patients generally should be sent to some support groups and have some specific therapy for smoking cessation. Obviously, we need to be working on body weight. And, quite frankly, in my clinic, it's very, very tough sometimes to have patients, I think with all clinics, to lose weight. I mean, I'll oftentimes just celebrate weight neutrality. They're not gaining weight, but we certainly send patients to the dietitian and do everything possible for weight loss. And now we have agents, GLP-1 receptor agonists, SGLT2 inhibitors, where we see very nice weight loss with the improvement in A1C. And lastly, antiplatelet therapy. So definitely patients who, for secondary prevention, so that have had cardiovascular events, there's no doubt that they should be on antiplatelet therapy, and most of these patients can tolerate aspirin. It's for primary prevention that it's a little sort of a bit more nebulous whether patients should or shouldn't be on aspirin, and really we need to weigh the benefits of the aspirin therapy as primary prevention versus the risk of a GI bleed. And in patients who are over 50 years old and have an additional cardiovascular risk factor in addition to the diabetes, no increased risk of bleeding, those patients probably should be on an aspirin, and that can generally just be a baby aspirin, 81 milligrams once daily. So that is definitely something to consider. And we'll end here with diabetes technology. Clearly, over the years, we've seen a lot of progression and a lot of innovation with respect to diabetes technology. For patients who are using intensive insulin regimens, and this will be almost all patients with type 1 diabetes where there's MDI or pump, I mean, they should absolutely be using SMBG. And, for type 1, I think standard of care now is to use continuous glucose monitoring. And obviously many of the pumps now are sensor augmented pump therapies is very important as well. And the checking should be pre-meal, post-meal, certainly if there's, before any critical activity such as driving, certainly when patients have symptoms of hypoglycemia. But here, it's not just for monitoring, but really it's to help drive therapy corrections, insulin dosing at meals, so on and so forth. So I think there's very little controversy no matter where you look with respect to glucose monitoring in patients who are on intensive insulin therapy. I'm not going to go over CGM in detail. Clearly, there have been a lot of advances there. There have been a lot of new studies showing that, particularly in patients with type 1 diabetes, you can get improvement in A1C with continuous glucose monitoring. The key here is that they have to use it, and that sounds very obvious, but they have to use it. Now, as I mentioned, with sensor-augmented pump therapy, this is becoming very important, and particularly for patients who are at increased risk of hypoglycemia. So this is key. And then intermittently scanned CGM, so-called flash CGM, also an important technology, and won't go into detail here either, but as you know, you have a receiver, you can scan it over the sensor and the patient can get the reading. It does not have the alarms that real-time CGM has, but some very nice data with this as well, and certainly a lot of patient satisfaction with these types of devices as well. Now, in patients who are not using intensive insulin therapy, so taking less frequent injections, this is sort of the quote that comes from ADA. So when prescribed, and this is talking about self-monitoring of blood glucose, when prescribed as a broad education program or part of a broad education program, self-monitoring of blood glucose may help to guide treatment decisions and or self-management, and this is for patients taking less. And I think this is absolutely critical, certainly in my practice. I mean, these might be patients, for example, on basal insulin, and we dose the basal insulin and do our insulin titrations based on the fasting glucose. So you at least have to have a fasting glucose in these patients. These patients, though, the risk of hypoglycemia is relatively low. They can get hypoglycemia, and they should be checking their glucose if they have symptoms. And then also, I think checking postprandially and at other times of day not only helps the patient know what's going on with respect to their meals and their glucoses after meals, but also with us as healthcare providers to know how best to intensify their therapy if they're not achieving their A1C targets, Are they having primarily fasting hyperglycemia? Is it mostly postprandial hyperglycemia? Is it a combination of both? I think we have so many agents now that target different glucose at different times of the day that this is critical information for us to have when the patient comes into the clinic as well. And this is true even of patients who are not taking insulin. So the quote here at the end there says, for some individuals, glucose monitoring can provide insight into the impact of diet, physical activity, medication management on glucose levels. And I think this is absolutely true. So I personally have my patients checking whether they're on oral agents that don't cause hypoglycemia, particularly if they're on sulfonylureas and not on insulin. But I think it's very instructive to the patient and certainly instructive to us as we're making treatment decisions with our patients. So with that, I'll turn it over for the last polling question, and then we have 2 more slides.
Wonderful. So the question asks, for people with type 2 diabetes not on insulin, which of the following do you typically recommend? A, no SMBG, B, once daily SMBG, C, paired testing, for example, before, after meals and exercise, D, 3-day, 7-point SMBG assessment, or E, SMBG upon symptoms of highs and lows. So while our attendees are answering this, there's an interesting question posed, and it's, bear with me, it's a little bit long. With the screening suggestions, I have had PCPs state that they won't test an A1C even with several risk factors if the fasting glucose is 100 milligrams per deciliter, as they feel they can't get insurance to pay for the test. Suggestions? When they finally get a hemoglobin A1C is diagnostic even with fasting glucose, that hits only in prediabetes. So how would you respond to that?
Yeah, well, that's something. You know what? I mean, if the fasting is in the pre-diabetes range, there are occasions where this is going to be someone who just has a lot of postprandial hyperglycemia, which really is the first defect, if you will, as you progress from normal glycemia to pre-diabetes. And that postprandial glucose can actually then cause someone to have an A1C that's much higher than would be expected based on the fasting glucose alone. Usually it's a little higher than 100, but I've seen those situations. But certainly as it's getting closer to the 126 fasting, where you can have an A1C that's higher. It's hard to respond to that. I prefer to get an A1C. I think if the fasting glucose is 100, and even if the A1C is a bit high, it's probably not going to be that high. It'll probably be less than 7. Certainly, in these situations, the ideal thing would be to check an A1C. But if it's not checked, this is a patient that eventually the fasting glucose will rise. They'll be treated. And that period of time where they sort of had diabetes, was undiagnosed, hopefully will be relatively short. There will not be significant hyperglycemia, so there will not be significant risk of microvascular complications. But I think in those patients, certainly that have prediabetes, I think it would be a good idea to get an A1C. But if it's not covered, oftentimes it's just impossible to get, unfortunately.
Great. Would you like to speak to the results, please?
Yeah, so I'm very pleased that no one said no SMBG, because I do think in these situations, again, even if patients are not on insulin, it's critical. And I would agree. I think that the paired testing is very nice because it's not such a burden on the patient where they're having to check, 7 or 8 point glucose profiles, but they can check, particularly before coming into the clinic, check, around breakfast, a fasting and a post-breakfast one day, maybe a fasting, a pre-lunch and a post-lunch another day. So, kind of whatever, there's no written rule about how it's done, but at the end of the day, it's to give them and also to give us some good information with respect to how they're doing in the preprandial or post-absorptive state and then in the postprandial state. Because I think it can help us a lot with our education with respect to diet and exercise, and also give us information to make much more rational treatment decisions from a therapeutic perspective with medications as well. And this is what I'd been talking about before was ADA, some of those quotes, and this is AACE, so the American Association of Clinical Endocrinology, sort of agrees with that and says that blood glucose monitoring is an essential tool that should be accessible to all patients with type 2 diabetes, regardless of whether or not they are receiving insulin treatment. It provides immediate feedback regarding glycemic control, and it assists the patient with their education, understanding, and behaviors. I think particularly, when I get my patients, and most of my patients are Mexican Americans or Mexican, and I tell them to check their glucose an hour and a half to 2 hours after their, the tortilla-laden meal, and they see those 350s, 400s. It is a very strong way for them to really realize they need to cut back, and often they can't eliminate, but at least, again, portion control. So I think that's critical. So the ADA, and I would say AACE also, standards of care, they provide a comprehensive evidence-based recommendations for the management of diabetes. They are focused on individualization of therapy, and not only for glycemic control, but other comorbidities, particularly cardiovascular risk. And, sort of with this ever-changing landscape, both pharmacotherapy and devices and new data coming from trials, one thing that the standards do state is that this is sort of a living document, and they're not just going to be updated. This is for ADA annually, but they will be updated throughout the year if new and significant updates come up. And then I would say, definitely, if you haven't already done so, and I think many of you probably have, that it would be a good idea to download these offline. And another site it's professional.diabetes.org. But quite frankly, if you just Google ADA standards of care, boom, the PDFs will pop up. And I think the abridged version of this is very nice as well. So with that, I want to thank you for your attention, and I'll turn it back over to Mary. Thank you very much.
Thank you, Dr. Frías. We do have time for a few questions, so
Great.
I'm going to start asking. The first question asks, how long do you have to wait for another sample? So I'm assuming this means the second sample after you've had one abnormal.
Oh, you could just do it the next day. So we want to know that patient sort of here and now. So, but it's sort of as soon as possible, as soon as reasonable. But, I wouldn't wait more than a couple of weeks. So if they come in and they're fasting glucose, or usually they come in and they've had a fasting glucose, you get it a couple of days later in the lab, and let's say it's 140, but the patient's been totally fine, totally asymptomatic, give them a call and say, can you come in tomorrow, sort of thing. So there's and that's why it could even be from the same sample. If that day you happen to have drawn the right tubes to get an A1C and a fasting glucose, and both of those come out high, there's no, that basically makes the diagnosis. So short answer is ASAP. But it's not an emergency, but as soon as possible.
The next question asks, what is meant by a clear clinical diagnosis? We get referrals where the tests are not abnormal, but the provider wrote a diagnosis of type 2 diabetes.
Yeah, so, it really is, it is the test. So the clear clinical diagnosis would be, and it's never 100% because other things can cause it, but would be someone who has been losing weight, who is urinating, 5 times during the night and all day long, so polyuria, is extremely hungry as well, so polyphagia, has blurry vision. So all of the typical sort of symptoms and what you get from sort of the catabolic effect of being hypoinsulinemic. So kind of that would be the clinical picture that you would have. But if the tests in that case are all normal, that means something else is going on. They may have diabetes insipidus. They may have, losing weight because of cancer. Who knows? There could be a laundry list of things. But so it needs to be sort of all of those symptoms. And if the random glucose, if they happen to come in after a meal, was over 200, that sort of makes the diagnosis. Or, the A1C is 10% and they have symptoms. There's no need to sort of, I need to confirm with a fasting glucose, or I need to repeat the A1C. There it's just sort of obvious. But if they have all those symptoms and everything is normal, their glucose is 80, their A1C is 5.4, I would say you need to start looking for some other cause for these symptoms. It's not diabetes. Diabetes is diagnosed based on glucose, either the fasting glucose and the A1C or the 2-hour post-glucose challenge, which we really don't do in non-pregnant patients.
Okay. How is fatty liver disease diagnosed and related to a diagnosis of diabetes?
That is a very good question. So, fatty liver disease, it's NASH, or non-alcoholic steatohepatitis, can only be diagnosed with a liver biopsy. But fatty liver, so when you talk about fatty liver or NAFLD, it just basically means that the liver has greater than 5% fat, so there's an abnormal amount of fat. Generally, that is diagnosed with imaging studies. Usually it's a diagnosis that's made incidentally when someone goes for an ultrasound of the gallbladder, let's say, and then it'll come back saying increased echogenicity of the liver consistent with fatty liver disease. So it's a diagnosis of exclusion, so the patient can't have alcoholic liver disease, so they can't be sort of excessive drinkers, although there are patients that can have both, and can't have a number of other disorders that are very rare that can cause increased fat or be on medications like tamoxifen can increase liver fat, so can prednisone. But in general, it's kind of a diagnosis of exclusion, and it is either an ultrasound or there's some other specialized imaging. And we happen to have it in our office, and it's called transient elastography. So it also looks not only at liver fat, but also fibrosis. The liver function test can be stone cold normal, the ALT and AST, and the patients still have fatty liver disease, but they might be high normal. But certainly in a patient with slightly elevated ALT and AST and diabetes and no other liver sort of risk factors, it would be an ultrasound. The issue, though, is that there's not much to be done about it today. The two medications, and not to go on too much about this, that have bed studied that are diabetes medications are pioglitazone and liraglutide. So the GLP-1 receptor agonist, basically Victoza, neither are approved for use specifically for fatty liver disease. But if you look at the American Association for the Study of Liver Disease guidelines, they definitely recommend, at least considering pioglitazone in patients with diabetes with biopsy-proven NASH. So I think until we have some therapy, the bottom line, the best treatment for fatty liver disease is actually weight loss and just excellent glycemic control as well. And then maybe if someone has fatty liver disease, I will generally go a little bit more towards the GLP-1 receptor agonist. And there's some ongoing programs now with semaglutide, and there will be with some other GLP-1 receptor agonists at different doses than diabetes, specifically for fatty liver disease. So I think we'll know more later. I'm sorry for that long response. But it's a very interesting topic.
Thank you.
So maybe next year we'll do something on fatty liver disease when we have some medications to treat it.
Okay, I think we have time for one more question, and it asks, do you recommend the National Diabetes Prevention Program? It showed better results for prevention than for metformin.
Yeah, no, I think definitely, and it absolutely did. So that program, I think is very important and really targets weight loss. And when you get sort of the mean weight loss of 7%, certainly if you can get to greater than 10%, it did show that actually. So that's very good. But oftentimes patients just cannot lose. So I think when I talk about metformin for that subgroup of patients, those were patients that did particularly well with metformin, and probably as well as diet, some of those patients anyway. But that needs to be in conjunction, without a doubt, with attempts for weight loss as well. So generally, I think probably it could be a stepwise approach. There's certainly no rush, and I don't like to put patients on more medication unnecessarily. So I would say let's start with 3 to 6 month trial of whether it's the diabetes prevention program, type diet and exercise, or just, anything to try to lose some weight, usually with caloric restriction and some physical activity, at least 150 minutes weekly. And if that is not working, then I think, and the A1C maybe is rising in the patient, then I think the consideration for metformin could be important. You kind of nip things early. So I wouldn't use it certainly without diet and exercise guidance as well.
Wonderful. Thank you for a wonderful presentation. For all of those questions that were submitted that were not answered, we will be able to answer them in a post-webinar blog, which will also be available on the website. Thank you, Dr. Frías. This was wonderful.